She's the professor of awesome, the administrator of everything, and she knows a lot, and we're going to learn about it. So Dr. Jacquie, you come on up here. Everybody give her a round of applause. Okay, so give us a little bit about, because you're everywhere in terms of academics, your own clinic. For those who don't know you, give us a little bit about Dr. Jacquie Pei.
My name's Jacquie. I'm a professor. I'm here at the university, and I'm also a psychologist. And those two things get to work really close together for me, which I really like.
Yeah.
I like that I can, put the stuff together quickly, right? The research and the practice, and how do we plug it in? I'm super interested with that. And in fact, I get to work with these amazing people, and we talk a lot about, it's one thing to want to know stuff and to learn and get the research. It's another thing then to say, okay, so now what? Like, what do we do with it? So what? And I love that I get to kind of sit in that in-between space and okay, I want to know the science because it's super cool, but if it doesn't actually do anything and doesn't hit the ground running, like, what are we doing, right?
Dude, see, like, what are we doing? Like, what are we doing? And this is why I love Dr. Pei. And I tell you, I've had the opportunity to go all over the world, and honest, there's some segments I do that I'm quoting this lady verbatim because she's great at explaining it. So let's get into that. Like, you have a real knack for sharing with us layman's. Like, you're right in the middle, like, you know what's up, and then you know how to talk.
I'm a simple girl.
Yeah, but you can...
I have to boil it down. And I like visuals. I don't know. I like pictures. I like seeing things. If it doesn't make sense to me,
So, like, look, dude, you're CANFASD intervention lead and senior research lead. You know what's up. But let's get into it.
Okay.
Let's get into mental health because it is so common. Now, we know at least 82 to 90% of individuals exposed experience at least one mental health issue in their lifetime. Anxiety, depression. Why is it so high? Like, give us a little bit about into mental health and FASD that way. That's a high number.
It's hugely high. Well, and I saw the hands go up.
Yeah,
you
almost
guys know
everyone.
It's
right?
hugely high. Like, this is no surprise. This is something we're living with all the time. And it's not just present once, it's present sometimes chronically, so long term, and sometimes recurrently, meaning round and round and round.
But
and you kind of come up and you're like, okay, we're on it, and then boom, we're not on it anymore. And then now we're on it again, and you experience those cycles. And what's worse is those cycles aren't always predictable. So it's like, okay, this is how it looked last time, and now here we are again. Oh wait, it's different. Now we're like reinventing the rule book again. And so that's something we see that's really prominent. Why, he says? Why? Okay, well, we don't entirely know. We're actually just having a conversation as researchers about how little we do know. We know there's lots of different things that contribute. We know that prenatal alcohol exposure changes the brain. We heard about that. We heard about the networks. We heard about the biome. We heard about all of the stuff that's going on that contributes to a unique brain. So we think that has an influence. We know genetics has some kind of influence, right? So there's something maybe going on in terms of maybe there was parents who maybe struggled with some mental health needs. We also know, because of these unique brains, that life isn't always easy. Sometimes the world doesn't make sense. Sometimes what we're seeing isn't what they're experiencing. Like, I sometimes think, how frustrated we get sometimes saying, why does this keep going wrong? Or why is this day good and this next day is bad? And that's frustrating, right? Imagine living that. Imagine that being your own reality. Like, it's frustrating enough from the outside in where we're trying to support the people we love, let alone living that.
Or not being able to know what's going on. You just feel anxious and awful all the time, but you can't even do like an internal systems check.
Sure.
Every decision you make or social interaction is a 50-50 crapshoot, whether you get it wrong or not, right? And then you get all that backlash.
And then people will come to you and they say, well, why did you do that? Like, why did that happen? And they're going, because the language to explain it isn't there, because they also don't know. And as caregivers, you see it. You guys have that insight. You recognize this. But then what about the educators? What about the teachers out there? What about the community members? What about the police or the justice system if you're in that space, right? What about the mental health providers or those clinicians who are supposed to be meeting you and your people where you're at, but instead are kind of going, well, we don't know, and so we're just not actually going to do it because we're a little confused.
And then the barrier to entry for believability, let alone then treatments.
Sure.
Right? And then going into even emergency, I bet you everyone's got a separate story to some degree. In fact, Dr. Mella is doing a 100%. Study about the emergency room visits. Okay, we get that there's gaps.
Oh, yeah.
And it's also important to know that there are things that we can do. But it comes down to us recognizing signs and symptoms and changing our lens sometimes because, you know, Jackie, grief and loss gets in the way. We want our kids to do well. Our kids want to do well. And so when there's repeated failures on both ends, from where they interpret, the parents are interpreting failures, the individual is interpreting failures. So we're not even able to frame it for the families and the individuals on the spectrum that hope is even possible because we're not even believing people for the most part. Because why? Our kids look normal, they talk normal, and yet when they act like this, the royal we say it's attitude, drama queen, that, you know, just get through it, just get with it. And so you're also telling me you know that frustration that the families feel.
For sure. Well, and I think for families, you guys know it's up and down. It's difficult to communicate. And then you go into with systems of support and try to communicate that. And their response is either to judge your kids or judge you. And boy, does that ever make it hard to reach out and ask for help, because it's like, okay, now I'm to blame. And now I don't even want to ask for help, and I desperately need help. But all I do is I feel like I walk in and people look at me like I've done something wrong. And you know, this failure to understand is a problem. And it doesn't mean there's no hope and we're going to get there. We're going to talk about the opportunities. But I think before we get to that, we actually have to sit in the frustration a little bit.
Sit in the shit. That's what we call it.
Sit in the shit, because it's real. It's real and it sucks and you're not alone, and we need to know that. And that's why we do the work we do, because the more we learn, the more we can gather this science stuff that if people are saying, I don't believe you, the caregiver, because heaven forbid we recognize your expertise, but maybe as we get more science and more stuff and we can say, hey, this brain looks different. This, you know, microbiome is different. Here, people, look at this. They're not making this stuff up.
This stress response system is different.
Stress response.
They see the world different.
Right. And the more we can put that stuff in your hands. So we need to say, first of all, this is super frustrating, and a lot of people are misunderstood and they are not seen. And that misunderstanding is hurting our kids and our families and our caregivers. Part of clearing up that misunderstanding is us getting some of that information we can put in your hands that can help with convincing. And then part of it is we're going to talk about is using that understanding to say, so what else can we do? What else? What are solutions?
Agreed. Now let's go into like the specifics here. I know you're so good. You're like, I haven't seen it, but you're so good. So this is what we're talking about. But those are the common ones: depression and anxiety, right?
Yeah.
So depression and anxiety is just as common, or maybe even more common, than externalizing issues with individuals with FASD.
Yeah.
Okay.
I really think this is an important point, and I think you guys know this really well, but disruptive behavior is super challenging. It gets in the way, people see it, it creates all problems, and it creates these impressions that our kids are bad or malicious or all of these judgments that I'm talking about. But what we're learning, the more work that's being done, is that more prominent are issues with depression and anxiety. And even when we do see disruptive behavior, that's often related to depression and anxiety. We're not talking about kiddos here who are adults or adolescents or any age that you're supporting. We're rarely talking about people who are intentional and strategic and oppositional in the way they're behaving, even though we hear it characterized that all the time.
Yes.
These are not antisocial folks. These are individuals who are struggling to manage these strong emotions in ways that look behavioral. And I just can't tell people how important this is. Like when I talk to community groups and educators, I'm like, if we can start seeing the people we work with as folks that might actually be sad or insecure or confused or anxious or scared, what would our responses look like that might be different than if I keep saying bad and malicious and willful? Because when I talk to a teacher, for example, and I say, what happens if you thought Johnny was actually scared and that's why that book went flying across the room, as opposed to Johnny was trying to be disruptive? What are your different strategies? Because sometimes they have great strategies, but they're so busy seeing bad, which was what we heard earlier on, right? They're making these assumptions. You're talking about that, right?
Mean, right?
Mean.
Bad,
this is a mean kid, a bad kid. So then they're saying, okay, now I have to do these consequences that teach them about the consequences of their behavior, which make no sense with somebody whose brain is working differently. Like it makes no sense.
It makes no sense because, well, the goal of a consequence is when the individual gets into that same situation again, they remember the pain of the consequence so that they'll make a different decision. give or take, right? Cool? That's what's up. And so here's what we know about our kids. It's not that they don't know. They can tell you the rules. They can tell you what's going on. But it's in the moment. It's not what they know. It's what they do with what they know in the moment. And how frustrating is that to have the words on the tip of your tongue or to know, okay, shit's going down and I know I should be doing something, but I know and I'm scared, and then it ends up turning what it looks like a mean brain. Because as Dr. Pei has taught me, they get this feeling like in their stomach, you know, and they don't know how to release that. They don't know how to manage those feelings like we do. And then boom. There's an explosion, and there's way more repair than needs to happen if the royal we were empathetic with our approach. But it's hard to discern with even the inconsistencies and the up and downs, which is also, you know, a part of it. And it's exhausting for you because there's no baseline. How does somebody tease out maybe some signs and symptoms that this is a little bit more than like a Blue Monday?
I can tell you how we do that in lots of folks. And how do we do that with folks with FASD? I don't think we know. I think that we know that a Blue Monday is different than a sunny Tuesday and a purple Wednesday, I'll call it.
Yeah, a fantastic Friday.
Yeah, I think one of the things is we're starting to notice, and we're starting to talk about a little bit more, is first of all, one size does not fit all. We already know that really clearly. And that applies not just between individuals, but within an individual, in that the relative stability of a mood. So sometimes when we talk about depression and we'll say, oh, depression, to be depressed, you've had to be depressed for a certain period of time. That means you have to be 2 weeks when you're really, really low and you can't get out of bed and life is terrible and whatever. That's depression, right? And we have all these characteristics. But for folks with FASD, we don't necessarily see that same stability in emotional expression in any way, shape, or form.
Yeah.
So depression might look like depression on a Monday, okay on a Tuesday, depression on a Wednesday, okay on a Thursday. So we have to actually reframe a little bit as to what we're thinking about in terms of on average or generally speaking, or even rather than are you always this, what are the mood states that you experience that are actually causing problems, and when are you experiencing them? What are those rhythms? So whether you have 3 blue days a week, then let's talk about depression. So even if the other days are happy, that's great, but let's operate from those spaces, even though that's not your status quo.
So it's almost like rule it out first, and then instead of including it last is what's going on. Like, talk about depression first before like it escalates. So if you're seeing small patterns, maybe it's something to look into until, you know, the secondary becomes tertiary.
Yeah, I mean,
what I mean, like the symptoms.
Look at depressed mood different. Look at depressed mood different. It's not about having a depression. Look at depressed mood different. And if somebody's struggling with depression 3 days a week or has depressed mood 3 days a week, let's put some support in place for how do I deal with that with my depressed mood. Or I'm anxious lots, or I'm anxious every morning, or I'm anxious in these ways. And part of this is jumping us ahead to how do we stop just thinking about what is the worry, because I'm like, well, I'm worried about depression on these days, and I'm worried about anxiety on these days, and I'm worried about aggression on these days, right? Because it can be a mix. It's a stew pot. It's not like these are kiddos who fit easily into some diagnostic box that somebody's going to say, oh, here's the protocol I use now, which is part of the problem for clinicians, is they're going, this looks different every day, and I don't know what to do, and what protocol do I use?
Okay, good point.
I really often suggest to folks, instead of that, like, let's deal with what we have when we have, and let's set our goals around a better mood resting state. So let's say, here's what we want to do. This is what stability looks like. So how do we work towards emotional stability? And then any deviation, any difference from emotional stability is something that we want to be supporting and saying, what would be a protective factor, or what would be an exception?
Yeah, here you go, dude. I can see. Here she goes. Okay, here we go. Here you go. Here you go. Okay, dude. Okay, so let's move on. She's getting fired up. All right, so worry. Okay, so can I say this? Worry and sadness can dress up as defiance.
Yeah.
Think mean brain, scared brain.
Sure.
Okay, it's not willful. It's the nervous system talking.
I mean, let's ask the question. Sometimes it's going to be willful, by the way.
Yeah.
Because they're human beings.
Yeah,
Sometimes
but
we're willful.
okay.
But
great.
Ask the question. What's your word? You say pause. You
Yeah, internally,
so, we all need to pause, and that applies to even how we all make assumptions, and we say, oh, I observe this, and then I conclude this. All of us. I observe this behavior and therefore I assume it's this. Because if it were me doing it, it would mean this.
We think they think the way we
Right.
think they should think.
So when we're talking about FASD, we say pause. I see this, it may not be for the same reason it is for me. Oh wait, it could be scared, it could be sad, it could be frustrated, it could even having the questions and teaching the pause, as you always do, matters. And I think when I talk to other folks outside of caregivers, I tell them, think sad and think anxious first, because I like them going down a path that's different than willful as their first stop. Let's not start with willful.
Well,
that should be our last
because,
one.
dude, your nervous system starts to do shit. If you think I'm doing it as a clinician, right? And so then you have a cognitive bias. So yours,
That's right.
your thing is think sad, anxious first to a clinic. Start there, dude, right? Instead of the stigma, because our folks get called like they're enabling, you know, like they're helicopter parents. Do you ever get called that? Eh? Yeah, that's right.
Yeah.
But their kids need that much support, and you are doing so awesome. Here, I want to get to this. I was going to ask you because it was excellent. Hold on. Oh, how do we tell if it's FASD or if it's just teenage assholery, like you mentioned? You know, that's hard, right, to discern? Because then do I consequence developmentally appropriate, or is this something I have to meet with empathy? Because parents don't want to be run over or taken advantage of. Does that make sense?
Yeah, it does. I don't have an easy answer. You guys will know this better than I do. I think the behavioral stuff, like I think if we're saying, oh, I want to help you to be successful, I want to set expectations, I want to give you something to grow up to, because as we already heard today, folks with FASD, their brains are growing and learning and developing, so let's set expectations and give them opportunities to grow. We gotta, because these brains will respond. But I think the growth opportunities occur before the behavior. So that means the growth, this is big time, because I think that like anyone, we learn best in structure and we learn best when expectations are laid down in advance. So all of those learning opportunities, when I don't want you to be the asshole teenager, they actually happen when we're calm, when we're cool, when we're not dealing with stuff. As soon as emotions get amped up, that goes out the window, and what we do, or are we learning, and we heard about it from Dr. Bodner, about sort of differences in stress response systems. The more our folks get amped up, the learning has gone out the window, guys. Those are not going to be this rich learning opportunities to just say, you've done this bad, I'm going to now consequence you. It's more in the structures and stability and responsibility. So when things really calm, we might come back to, okay, this all went down, whether it was about anxious or you being a bit of an asshole, we still need to think about how our structure is going to work out a bit better here. And maybe we can reevaluate structures, reevaluate support, or create even a restorative space where we say, hey, for whatever reason this went sideways, you were anxious, you're depressed, or you were being an asshole, we still need to kind of fix things. And so that's what we can create. And those are our learning spaces, as opposed to when we're in those anxious or sad or dysregulated or just plain angry and willful spaces. So the actual learning occurs before the behavior occurs. And so often we think, but I'm dealing with this and the consequence has to come down now. And none of us learn well that way. But kiddos with FASD or folks with FASD will absolutely not learn well in those moments. And you guys are the experts, and you know better than anyone that those are generally the moments where things get worse.
Right, absolutely.
And it just gets worse when we try to say, we got to lower the boom, like this is time for a consequence. If I don't respond now, this kid will never learn. And I'm like, no, you know what? You respond like that now, they're still not going to learn.
Nobody learns when they're limbic.
This is not going to happen. We manage the moment. We manage it with empathy, compassion, and care. And then later on, we have the opportunities for teaching, restoration, repair.
Beautiful.
And those are the spaces where there's readiness. And then it doesn't have to be about judgment. It doesn't even have to be about whether or not you were an asshole or not. We all are sometimes.
Agreed.
We don't have to go there.
I'm going to transition.
Move us on.
That comes up often, thoughts of suicide. In our free group, we get that often. Our paid groups, we get that often. You're, I believe, the person to talk about that. Give us some insight into what we know, maybe what's going on, because we know there's an increased risk in both in thoughts and behavior of the neurotypical population, right?
Yeah, suicide is scary. Suicidal thoughts are scary. Suicide is scary. It's terrifying. It's something that's super hard to talk about. It's a trigger topic. It's rare for people not to have some kind of emotional response to that, even personal experience with that. So it's terrifying. It's really hard to talk about. This is something that we hear about a lot more for folks with FASD. We don't know entirely about it, but we do know that there's more mental health needs, there's more anxiety, there's more depression. These are folks that don't always feel like they fit in. This is also a group who could be very impulsive and whose emotions come on real strong and who really may just act quickly and not always have a lot of thinking about what they're acting on. We don't see any single pattern. We don't say, oh, this is what everything looks like, or this is how we can anticipate or predict. We don't know. We really don't know. Do you know, in general, sidebar, guys, but in general, and anybody, we are terrible at anticipating who is actually at risk of attempting and dying by suicide. We are not good at it. It doesn't matter who. Any human being. It is one of the areas in clinical psychology and all of our clinical work. We say, oh, how do we assess for this? We are terrible at it. And there's a lot of data that says we're just about as good as flipping a coin. So add in unique brain like FASD, and we're not good. And so clinicians are struggling, families are struggling, and we're doing the best we can to say, what does it mean to offer the kind of supports that keep us all safe and well and healthy? And how do we work towards those mental health goals and not just worry about it and live in the fear?
Okay.
But it is something that we're starting to look at, starting to study, and starting to talk to clinicians about, because we're saying, how do we actually get our clinicians less afraid of this topic? Because families are afraid. But
Afraid if you say it, they'll think about it, right?
Sure.
You know?
What happens if I mention it?
Yeah.
We'll just put the idea in
Right?
our mind. We're worried about all of these things, and clinicians are worried too. And so, unfortunately, clinicians, when they get worried, they go, oh, I'm a little worried about this. I don't actually feel like I'm competent, so I can't work with the population. So then you go door to door to door, and as soon as you say my person has FASD, they say, oh, I'm sorry, I can't work with that person.
Yeah.
Which actually takes our higher rate of mental health issues and our higher rate of suicidality and less service provided. So we're saying, well, how do we actually do a better job? Because we all have to accept that there's a lot we don't know and a lot we have yet to learn, and that we're studying as right now, like we're trying to understand so we get better.
But as a clinician,
But we gotta all get on board.
sorry, can I ask you some best practices? So, because for example, my kiddo, he would tell me in detail he was gonna, like kill me or himself. It was, how do I take it seriously every time? You know how you're the parent, you know best, but if you hear it first, do you, like a best practice to go get a risk assessment? And are those particularly valuable for individuals on the spectrum? Like from what you know and understand, I know you don't have all the answers, but like some practices.
We say always go. If you're scared, go. Go for help, get a risk assessment, talk to people, reach out, go. And you guys know better than anyone that means sometimes you're knocking on a lot of doors, and there are going to be times, frankly, when you're going to go to the hospital, you're going to say this is going on, and after your 25 hours of waiting, you're just going to hear, yeah, you're all fine, and go home, right? I get that, but I do think that continuing to show up and continuing to do that is something that is necessary, because we don't know what we don't know. So when are we really worried and when aren't we worried? Whenever I am in a situation where we say, this is somebody who's saying, I want to do this, I want to hurt myself right now, and this is what I want to do, I'm like, go. I would never not say go. Okay. And that's big, and even though it's scary, that's safest. It really is. And as we get better, maybe we'll have better information and instruction. And then as much as possible, I like to say, when we can have appropriate mental health support.
Good segue.
Yeah,
I'll go segue number 4.
We want you to have the right mental health support first. If you're fortunate to be working with a therapist you think kind of gets it, then sometimes you come up with a better safety plan. And you say, okay, I've actually got a person, so we have a safety plan. So when we're in this place and we're scared, we actually can reach out. Sometimes there's therapists who'll say, okay, text me and I'll respond, or we'll talk, because I actually know the kiddo better, and I'm in a better position to make an individualized, and Dr. Rodman was talking about that precision health that we're talking, right? We want to get better at knowing the right answer for the right person. We'll get there one day.
Well, let's talk about those protective factors.
Protective factors.
What are some of the protective factors, right? We're going to go Hope Floats. Nobody got anyways.
Yeah.
Great title, great movie. But tell us about that.
Number one protective factor is relational support. We talk about that in lots of different ways. In other words, you, the caregivers, you guys are a huge difference maker. Having that stability and having that connection matters. It's not always enough, and you can be amazing and you can do absolutely everything right, and things can still go wrong. But it's still a huge difference maker having that. Other relational support sometimes include a good therapeutic support. And that therapeutic support is not only for the person you're caring for, but for the family, for you, for other siblings. Sometimes that really matters, because when we're talking about mental health, when we're talking about suicidality, we're not talking about something that affects a single person. It affects an entire family unit, and sometimes even more than that. So what kind of relational supports are on board? When you're fortunate to be connected to sort of networks, having connections like mentorship or family supports or each other or
Community, like we have, yep.
And all of these things, we need those kind of supports to reach out, because otherwise you feel buffeted by the wind. You feel like it's this one way one day, and nobody's giving me a rule book here. Nobody's giving me the checklist, because there isn't a checkbook list, there isn't a rule book. You're not alone. And so only in those relationships do we find space for that dynamic responding and that meeting people where they're at.
I like that. Dynamic responding.
Because we got to go with the flow. We got to work together, and relationships allow us to do that. Rule books and checklists don't. They're rigid, right? Protective factors are also identifying strengths and meaning, and this is where we start to, even when we think about suicidality, we don't just think about anymore. We're moving away from saying we're really afraid of you dying and hurting yourself towards, in addition to keeping you safe, how can we also think about ways to promote living? How do we think about what does it mean to bolster your mental wellness, your health, and give you reasons to want to be alive, as opposed to only working and thinking about the fact that you're afraid of dying? So what does it mean to find meaning? What does it mean to actually have a place and space where you're contributing meaningfully? This is part of that expectation even. Like, it's not enough for us to do for, but to find ways that you, the individual with FASD, do for me. What are you doing for me? What are you giving to me? What am I getting from my relationship with you? How are you contributing? How is your being here actually matter? Because the more I see how my life actually matters, then I've got a little something to hang on to say it's worth living. And again, day to day, you got to have a reason. So life promotion.
That's it. That's number 5. Yeah, it is number 5. And this happens to go, you guys okay? You all right? Everyone just listening. Okay, so I first learned this from the THO, the Towards Healthy Outcomes, which yourself and an awesome team put together. You know, the domains, and for suicidality, you flipped it on your head, and it was so beautiful. When we did it in our group, they loved the idea of life promotion.
Yeah.
So instead of the other way, going, you know, you don't want to do that, our messaging is about promoting life, and a part of that is finding their strengths and helping them find their niche and find their area where they fit. It's not easy. And some neurotypical adults, it takes a long time to find that. But these are the protective factors against having our guys go down that road, because it's really, really hard. And we were trying to just mitigate, because when you mitigate and you can create a good environment, that's where we could teach skills.
Sure.
When the brain feels good, the body feels good, it can learn, because they want to do well. This is not like from a want, right?
This is normal. This is human normal stuff. Like, I mean, individuals with FASD are fundamentally, we're talking about human beings who, like everybody, strive towards health and wellness, and they want to feel good, and they want to contribute, and meaning matters. And I think we're afraid sometimes, and mental health can really dominate the picture, right? And we're worried about the aggression, we're worried about the anxiety, the depression.
We're worried about making a mistake too.
We're worried about making a mistake. We're scared. And so what happens is we spend a lot of time looking at the things we're worried and scared about, because that's normal. It's got our attention. And what we're saying with life promotion or with mental wellness is that we're not ignoring all those things we're terrified about. But we have to look at something else, because if all we talk about and all we think about and all we focus on is our worries, then we don't give our people anything else to think about. they're going to be hearing all about their own worries, their aggression, their depression, their suicide. But what else do they get to hear about? What's the rest of the story? Is that you've got strengths, and look at what happens when you're happy. And you know what, instead of just talking about what anxiety looks like on you, let's talk about what happy looks like on you, and how I notice what's going on in your body when you're feeling good or you're calm today. Let's talk about calm, and how does calm feel, and let's be in
Because
calm.
they might not know what that emotion feels like,
let's
right?
balance it, and let's be in these spaces that are protective as much as we possibly can, and at least as often as we're in the spaces that we're worried about. And let's capture those and say, wow, something went really right today. Let's talk about that. Something felt good today. Let me put that on, because I'm telling you, when I think it went wrong, we're definitely having those conversations. Are we spending as much time on the conversations about what went right and how it felt and what
Yes,
did your body
because you know why? Success leaves clues. Success leaves clues. We have at our group, we have caregivers, and they'll share wins, right? We have wins, we have events, and then people can ask a question, right? But when they share wins, inevitably my question follow-up is like, so how'd you do it? Like, how was the win? Let's deconstruct the win, because it's not only you could do it over and over again, but it leaves clues. Like, what was the environment like? And now when you start asking questions about the intangibles to when they were doing well, did they eat well? Did they sleep well? It doesn't mean you have to track everything, but you can start putting the data together in your own home, and then you can start modifying the environment as much as humanly possible. And it's not always easy.
Wait a minute, you mean we're all researchers, and that everybody here is doing their research study of one as well? And just as we in a research setting are trying to modify and say what's protective and what might work, and here's new ideas, you guys are doing this all the time, every day. And the more we can have conversations like this, the more you could say, hey, this worked, and we can go, oh, cool idea. Let's try that out in our great research setting here and see if we can kind of figure out more about why that worked. And then we come back and we say, and so this is how we're working together. We're all looking at the same questions, and we're all trying to find some solutions that are going to be more meaningful, and we just are doing it in different ways. And the more we have these opportunities to communicate, the better.
Yes,
and the more we're
dude.
engaging collectively in these research, not just you on your own, but all of us together.
Symbiotic relationship,
We're
right?
just getting better at, and more rapidly thinking about how we can answer questions in real time and not wait forever and ever and ever for one thing to catch up to the other.
Oh, dude. Isn't she awesome? Hey, isn't she awesome? Yeah, you can give her a round of applause. Okay. We're going to have time to answer questions at the end. And, dude, I can listen to her, and I could, I try to talk to her as much as I can. But it's very hopeful, right, Jackie? I know you turned your mic off, but it is.
A mic drop.
It is hopeful. I felt this a little before. Remember you had the cross ministry? Remember how awesome it was?
Yeah.
And that was from a massive influx of funding. That has gone away, but I feel like it's happening again, but it's grassroots more. Like, it's not top down, and it's more coming from people. And you having these relationships with labs and participating and being in their ecosystem, I think has a lot more benefits long term than, years where a government might decide to throw some money at it. You get everything together, because it was so fucking cool. You guys had trainings from, I thought these guys are going to get this shit licked in a year or two, how good it was, but you can't rely on that. So I feel hopeful because of this grassroots movement, man. And we're still glad you're here with us.
Okay, why don't you just remind me of something? I was just talking to these guys like at the break, and I have to share this. Because,
But hey,
we were talking about what's happening in the research space, right? Especially in Alberta right now and other places. But you know how when you're working with a kiddo or the person you're supporting, and if you can sit down at a table and you can get a nice wraparound team there, right? And say, oh, hey, here's like maybe a caseworker or social worker, or here's a clinician, here's a housing worker, here's a teacher, and you all sit at the table together, and sometimes you can generate a plan that's really meaningful. And sometimes the person that you're supporting can really be seen because you're actually working collectively and together, and something neat can happen. Because then you can say, well, wait a minute, this idea doesn't work for this reason, or this doesn't work for this reason. And so you can troubleshoot and find solutions because everybody's at the table, as opposed to having to tell something over and over and over again, right? It works. Well, research traditionally, we've kind of lived in silos. We've been that horrible silo stuff like you see in the community, right? That doesn't work. So what we're trying to do here is to say, what if we get all the researchers who do research in different spaces? What if we all sit at the same table? Yeah, I know, right? They're like, oh, guys, you get really slow to the draw here, aren't you? I know.
You know, all these parents
I know.
would just collectively went, you don't say.
Really, Jacquie, we've known this a lot. And they're like, why are you explaining a collective team approach here to us? And I'm like, okay, we pay attention to what you guys are doing well. We really do. And we're like, you guys are right. We actually have to work together. Hey, if we all sat at the same table and we shared this stuff, can we accelerate the way we work together? Can we be more responsive? Can we go back and forth better? Imagine how that might look. So we're learning from you that having wraparound support or having people from different expertise and different spaces at the same table allows us to do a better job of integrated intervention and understanding. So we're working on it. We're trying to figure it out. Yay, Alberta. So CMC may be changing.
Right.
And some of that stuff.
You remember that though?
Oh, yeah.
But I love what's happening. No, that's
in our own way. And
I think this lasts.
amazing.
It lasts when
You
the
betcha.
roots and the foundations and everyone's working together,
That's
right?
Well, and you heard how committed these folks are, right?
I
Like
love
these
it.
are people who are in it for the long haul. Like, guys, we got a dynamic
Yeah, we're
team.
doing it.
Like,
Now
let's
is the
do this
time.
thing.
Awesome. Dr. Jacquie Pei, everybody!